Dr. Indu Khosla, who's a consultant pediatrician and pulmonologist. She's associated with SRCC Hospital for Children and Nanavati Max Super Speciality Hospital in Mumbai, India. She also has her private practice called Dr. Indu's Newborn and Childcare Center in Mumbai. She's got a special interest in flexible bronchoscopy, sleep medicine, and mucociliary disorders. She's also been the core faculty for numerous modules for Indian Academy of Pediatrics. She's also been the winner of Manekji Firoksha Gold Medal in Pediatrics, and she's also been the national convener of NAPS module on sleep. She's also held multiple lectures at both national as well as international conferences, and she's got numerous publications in her name in various indexed journals and textbooks. I think it's a pleasure to have you with us, Dr. Indu ma'am. And now, without much wasting time, would like to hand over this virtual platform to Dr. Indu Khosla ma'am, who would be taking us through few interesting cases in pediatrics. Thank you so much. Over to you, ma'am. You need to unmute, ma'am.
Ma'am, yes.
Yeah, 1 second. All right. Am I audible, visible?
Yes, totally.
And slides are seen properly?
Totally. Please go ahead.
Yeah, okay. I thank JBCL for giving us this opportunity to talk about cough. In pediatrics, it takes even more significance because most of the cough syrups are now not cleared for use in children below the age of 5. Be it dextromethorphan and many other molecules which have gone off the shelf for children, and it leaves us, kind of gasping for breath with every child who coughs and every parent who coughs down our throat. Okay, and I thank Dr. Vikram for setting the ball rolling and giving me a platform from which I can take it forward. Now time on today to hear us. My slides are moving. Okay, yeah, okay. Now, normal children will cough more than 11 to 30 times per day. And a very interesting article by Dr. Andy Bush describes a child can cough up to 32 times per day. But try to impress upon the mother that this child's cough is normal and it is not easy. In pediatrics, unlike adults, we call any cough beyond 3 weeks as chronic cough. But it is very important for us to identify what are the associated red flags with cough, especially in children, and then take the management forward. Okay, and today environment has become an extremely important factor in the management of cough. With 6,000 sites in the city of Mumbai under construction, we are under constant siege. So to me, a coughing child, I would approach it in 4 ways. Is this a normal child and there's nothing else, but this is a normal cough? And trust me, this is the most difficult diagnosis for me to make because I have to exclude everything else and I have to convince the parent that this is a normal cough. The next important category of cough would be a child with a serious illness like cystic fibrosis, tuberculosis, and it is very essential to get this right and get it right at the earliest. The third is a relatively non-serious but treatable cause of cough is children with, like what Dr. Jaggi mentioned about the upper airway cough syndrome, gastroesophageal reflux disease. So this is a big group of children who cough because of these reasons. Then comes the asthma syndrome, which is on the rise. It is like a Pandora's box for us. When under 5 children cough with wheeze, we really don't know which of them will be an asthmatic and which won't be. And it's like a big box where all kids are coughing. And post-COVID, we have a huge chunk of children whose symptoms are overestimated both by the parents and by the child for a variety of psychological reasons which the family may be facing. But to me, when I see a child with cough, I quickly in my mind draw this graph and I ask the parent, did cough start and if the cough is continuing beyond 2 weeks and it is in a rising trend, from a dry cough it became a wet cough. This is an abnormal pathological cough. And you can see this by this graph, which is a rising trend. This is a graph over a period of 2 weeks and more. Now, if you have a child who gets a cough, gets better, is better for 3 weeks, 2 weeks, and then gets a cough again, this is like an asthma or a recurrent viral infection story. The third and the important category is a child who starts coughing, continues to cough 2 weeks, 3 weeks, 4 weeks, but the symptoms of the cough or the incidence of the cough or the persistence of the cough, intensity of the cough is reducing. Now, this is a post-viral infectious cough, which Dr. Jaggi mentioned, and it's a very, very big element today because not only we have the viruses which go on causing the children to cough, but we have the environment which continues to trigger them. When in doubt, judge. It's a very important, a very old Japanese saying says, when the character of the man is not clear, please look at his friends. Maybe you will have an answer. So if you don't know what this cough is all about, look at the associated features. Look at signs of weight loss, failure to thrive. Upper airways. We have kids with large adenoids and tonsils who have a postnasal drip or who have something like a stutter and they're constantly coughing. And I have lost count on the number of kids whom I've stopped inhalers because they were diagnosed as wheezing and it was just an upper airway cough syndrome because of the enlarged adenoids and tonsils. Look at the upper airway like a rhinitis, a polyp. Look for other things like a hypoxia and clubbing, which tells you something more serious which is happening in the lungs. Look for other deformities like a Harrison sulcus, a barrel chest. A Harrison sulcus could be a simple ventricular septal defect or anything with the left to right shunt. If it's a fixed monophonic wheeze, it is something else. It's a foreign body or a lymph node which is obstructing. Look for a stridor, you know where the etiology of the cough is. If it's asymmetric wheeze, it can never be asthma. A foreign body or lymph node could be the reason. Cardiac murmurs are very important. And hemoptysis is a very ominous sign, though not very common in children. With this, I will illustrate two simple cases which I have recently treated in my clinical practice. And I'm sure you would associate with them, as especially if you have pediatricians here in the audience. Now, 3-year-old who presented with persistent cough, mild fever since 4 weeks. He was treated with a gamut of cough syrups, bronchodilators, but his cough persisted. There was no obvious clear history of Cox contact asthma, A to B. He was a well 3-year-old child. The mom felt that the cough is now chesty. Now, many pediatricians today are very, very, I would say, ethical, and they wouldn't write an antibiotic. And as Dr. Vikram rightly pointed out, if you have a viral cough, please don't give an antibiotic. So this child was not treated with antibiotics, but his cough is going on for 4 weeks. So looking at his weight and height on the centile chart, he was the 25th centile. He had not dipped his centile. There was no clubbing, cyanosis, no markers of allergy. ENT was normal. He had occasional scattered chest signs. He was a happy, playful child who was continuously coughing. Other systems were normal. So routine investigations were done, a chest X-ray, a CBC, ESR, MAN2 test, which nowadays we don't do a MAN2 test, but it was done, it was a while ago, so it was done, and they were all normal. So here, thinking the fact that he had cough for 4 weeks and it was now a wet cough, we gave him a trial of antibiotics. We gave him coamoxiclav for 1 week, and surprisingly, he was much better. The mother came back to say he's 50% better. So his antibiotics were continued for another 2 weeks, and because there was an improvement. So what is the likely diagnosis? I know many of you must be jumping with the diagnosis. Yes, this is a child with protracted bacterial bronchitis, and the diagnostic criteria for these children are chronic wet cough lasting for a duration of at least 4 weeks, absence of signs of any other disease, like we have to rule out mucociliary disease or any other systemic disease, and perceptible improvement to 2 weeks course of an antibiotic. So the key here is that you need to give antibiotics for anywhere from 2 to 4 weeks. If you do a microbiology, if you attempt a microbiological diagnosis, or if you do a BAL in some cases who do not respond, you should have the organism that you typically grow is an H flu, Streptococcus pneumoniae, or a Moraxella, and the colony count should be more than 10 raised to 5 colony forming unit. Uh, there is an entity called as recurrent PBB when you have more than 3 episodes per year. Here, bronchoscopy may be indicated. These children need to be followed because they're at a higher risk for bronchiectasis. So this is a bronchoscopy finding of another child who had recurrent PBB, and we grew Moraxella, and this is what the airways look like. Sometimes the bark is worse than a bite. And this was a 6-year-old girl who gets cough on and off, has received bronchodilators in the past. So as a kid, she used to wheeze and she had received bronchodilators to which she used to respond. Now this time the cough was for 2 weeks, very short bouts, more in the day. Father had some illness for which he was admitted, but he was better and home now. On examination, she was a well-grown child. On exam, chest was clear, ENT was normal, other systems were normal. And we asked, when she came in coughing like this. I was scared to my staff and the people outside. And then I asked, this is something which we are seeing very often these days. Post-COVID, it has only been on the rise. And habit cough syndrome is a troublesome disorder and that commonly is treated or misdiagnosed as asthma. It's a harsh, barking, repetitive cough. It occurs several times per minute to hours at end. And the characteristic of this cough, it is completely gone when the child is alone or is busy with some activity or he's asleep. It's a typical cough. It's a deep inspiration as if the child is making an attempt to cough and then followed by a cough with short bouts of expiration. Here, counseling is very important. And if we have any cough syrup for these children, it would really help them because they cough so much that they are themselves in distress. Lot of counseling goes into this and lot of counseling to the parents required into this. My last quick case for the evening today, one video before I finish off.
Please.
Okay, just a second. So whenever we have the commonest reason why we get children with cough today is asthma. When you are looking at a child with asthma and when you're following up, it is very, very important to look at their devices and their techniques that they use. And many a times, irrespective of us teaching them 100 times, they're very innovative in their own ways. So this one message I wanted to give you. This was a video the parent gave it to me. I thought I would share.